Good afternoon, everybody, and welcome to the University of Tasmania's Island of Ideas online public lecture series, and also a special edition of the School of Medicine and Menzies Institute seminar series. Firstly, on behalf of us all, and as a reflection of the institution's recognition of the deep history and culture of this island, the University of Tasmania wishes to acknowledge the traditional owners, the Palawa people, and also the custodians of Lutruwita, Tasmania. And we pay our respects to their elders, past, present, and emerging. Hello again, everyone. My name is James Vickers. I'm the Dean of the Tasmanian School of Medicine, and I'll also be your MC today. Island of Ideas is a program designed to keep the ideas flowing during this time when we have the restrictions on movements. We're not able to offer our normal live public events. Each year, the university presents hundreds of lectures, forums, seminars, and workshops free of charge for students, alumni, and the wider community. And this is an important part of the university's role, and it's why we are hosting forums such as the one this afternoon. So just a few housekeeping notes before today's lecture gets underway. Your microphone, camera, chat function, and raised hand function have all been disabled so that the speakers are not interrupted. But we do encourage you to ask questions. That's an important part of the forum today. And you can do this by typing them into the question and answer function that you'll see on your screens. And hopefully a selection of these will be answered during the question and answer section towards the end of the presentation. And finally, also just to note that this lecture is being recorded for later access on our YouTube and SoundCloud channels. Now, this annual lecture honours the memory of Professor Arthur Cobbold, who was absolutely a seminal figure in the establishment of the medical school at the University of Tasmania. He also made major contributions to medical education and more generally to health policy and administration in Tasmania. The lecture was established in 2011, 2 years after Professor Cobbold's death. No early alumnus of the University's School of Medicine needs an introduction to Professor Cobbold. From 1964, when he arrived as Foundation Professor of Physiology, until his retirement 21 years later, he very much shaped the school and the lives of many of those in it. Arthur Cobbold also served as Dean of Medicine for 13 years, which is something of a record for a Dean of an Australian medical school. He was also remarkable as he maintained a substantial teaching load during his deanship, so he was very much in touch with the students and committed to student education. Professor Cobbold was an inspirational lecturer. He was also an active researcher and an excellent administrator. He was much loved by his students and over 3 decades had immense influence on medical issues in the state, particularly also as his time of chair of the board of the Royal Hobart Hospital. He was also very committed to the role of the Tasmanian School of Medicine as having a central purpose in helping to create and shape the medical workforce for the state. And this central purpose remains today. As an important legacy of his contributions, many of the senior clinical leaders of the state today are alumni of the Tasmanian MBBS and were taught by Arthur. So it's actually a most fitting memorial to the late Professor Cobbold that an annual lecture on contemporary medical issues continues to strongly influence thinking around health in Tasmania. The ideas generated in our university focus on solutions for our place, but they resonate far over the waters of the Bass Strait. The University of Tasmania seeks to instill in its graduates a sense of the unique place in which they've earned their qualification, as well as opportunities and challenges that come with this. The university also encourages a pursuit of excellence that globally connects our place-based research to developments across the world. We do this very proudly by presenting opportunities for people to learn about the best and most significant developments, in this case, in medicine. Today, we are here from our Cobbold lecturer, Professor Michael Breadmore. Following Michael's presentation, the Tasmanian Director of Public Health, Dr. Mark Veitch, the Head of Infectious Diseases at the Launceston General Hospital, Professor Katie Flanagan, and Associate Professor of Public Health, Nicola will join him for a panel discussion. We'll hear about their thoughts on issues related to COVID-19 and detection. We'll also have time up to 2:15 p.m. for questions from attendees. And now to introduce our main speaker, Michael Breadmore is absolutely an international expert in the rapid and accurate detection of very small amounts of substances in a variety of samples and situations. By way of his background, Michael is an analytical chemist and heads one of the university flagship research centres, the Australian Centre for Research on Separation Science, or ACROSS. His research interests have relevance from seeking to detect explosive residues through the development of new smart sensing devices. Michael obtained his PhD in analytical chemistry in 2001 from the University of Tasmania and was awarded a Doctor of Science in 2017. He's published over 180 peer-reviewed papers and has been successful with over $22 million of research funding. He has held 3 prestigious ARC fellowships, and his recognition includes the 2019 Eureka Prize for Outstanding Science for Safeguarding Australia, finalist for the Eureka's Best Young Scientist Award, Australian Research Magazine's Analytical Chemistry Field Leader, and Analytical Sciences Power List of the top 100 analytical chemists in the world. He is co-inventor on a number of patents, and he has 3 commercial products based on his research currently available in the market. So it's now with great pleasure that I call upon Professor Breadmore to deliver the Arthur Cobbold lecture.
Thank you very much, James, for that really very nice introduction. It's an honour and a pleasure to be asked to give the Cobbold lecture for this year. And I was a little bit apprehensive because I am an analytical chemist, and that's not really all that relevant to health in some ways. But given what we've been doing over the past 8 months, trying to find a better way to detect COVID, it actually is very relevant. And so I think it's a very timely topic to talk about. I've changed the title here from the COVID detectorist to detecting COVID because I will talk a little bit about the need for detecting COVID, how we detect for COVID, and what we at the University of Tasmania have been doing for the last 8 months. And that is very much a team effort. So detecting COVID is what we're trying to do, not being a COVID detectorist, which is very much perhaps about the person. So let's play the virus, not person. I'm sure you all know that our world changed significantly in 2019. It actually started a little bit earlier than that, back in December, with the first reports of the virus emerging in China. And in January 2019, it really started to escape from there to the broader parts of the world. I've got an animation on the right of the slide here, which shows the 5-day moving average of reported cases everywhere around the world from the end of January. So you can see by about April, pretty much COVID had attacked everywhere in the world. The colours there represent the intensity of the frequency of the number of cases. You'll see that United States, America, India, Russia have all quite high cases. And you'll also note that Australia there is relatively pale. We all know the reason for that, and that is our remarkable effort to isolate our country, to stop people infected with the virus coming in, the quarantine hotel situation by, again, if you come in, being isolated to prevent transmission of the virus. And when we have had outbreaks, again, we have taken action as a community to prevent the spread of that virus to protect us all. So we have done an amazing job in that regard. But even so, when you look at the global perspective, there's been 195 million positive cases and over 4 million deaths. And I think in Australia, we've been very, very lucky with how this has been handled. However, until we are all vaccinated, we are still all at risk. So this is some numbers pulled off the Johns Hopkins site for the United Kingdom. You'll see on the top there is the number of reported cases in blue, and in the bottom is the number of deaths. So you'll see in December last year, there is a spike in the reported cases up to about 60,000 at a 7-day average. And below that, there is a very high correlation with the number of deaths. If you look at the current spike that's happened in the United Kingdom, you'll see that that's at a similar magnitude to what's happened earlier in December, but the deaths on the bottom are much, much lower. And that's because of the widespread uptake of the AstraZeneca virus in the United Kingdom, which has not stopped the transmission of the virus because we're still getting cases, but it has reduced the symptoms and reduced the effects. So until we as a community are vaccinated to a high level, we are still all at risk. And that is really important when we think about the need to be able to detect the virus. If you think about the transmission of the virus, and this was a advertising document that was released last year, one person infects roughly about 2.5 people, which means that over 30 days from that one person, about 406 people are infected. Now, if we reduce the exposure, and one of the ways we do that is by self-quarantining, we can reduce how many people are infected. So if we go down to 50% less exposure or 75% less exposure, you can see on the bottom now that one person after 30 days has only infected 2.5 people. It's still important to recognize while that's lower, it's still more than one. So there will still be that virus increasing throughout the community. That was with the original strain though. And if you look on the right of the slide here, I've got data again from the internet on the 3 outbreaks in Sydney. And the blue one there is the current outbreak of the Delta strain. And you'll see that that's escalated much higher than the other 2 outbreaks there because of the more infectious nature of the Delta strain. It's approximately 2 times more infectious, which means that we need to reduce exposure, not by 75% now, but getting close to sort of 85, 90% to have the same effect as the original virus. So until we can stop the spread, we are going to be challenged. Now, the way the virus is spread, and you've probably all heard this already, comes from our breath and the virus particles that exit our breaths. And there's 2 types. There is what are called aerosols. And these are really small particles that contain some of the virus that will, when we inhale, cause us to become a host and become infectious. The other alternative is also droplets, but these are kind of heavier and they will move around the air and condense or collect on the surface where they can remain for a considerable period of time. And these 2 transport mechanisms are really the key to our mitigation strategies. So we wear face masks to, again, stop those droplets coming out. And we are asked to regularly sanitize our hands to avoid any of the viral remnants that we may have contacted when we've been touching things, which then either go to our food or go to our face. So understanding the virus actually allows us to understand how we can help prevent that. Even with that understanding, the virus actually lasts a lot longer than you might think. So the key relevant plot here is in the middle of the slide. And you can see these 2 color traces. The red one there is the SARS-CoV-2 virus, that's the COVID-19. The blue one there is the previous strain of the SARS-CoV-1. Importantly, if you look on the far left graph there, the aerosols are stable for at least 3 hours. So that means if there has been someone infectious in my office here, there could still be virus particles for up to 3 hours in the air that are floating around, which may infect them. If we now look at those larger droplets which have collected on surfaces, then you can see with cardboard, there is still active virus 24 hours. So that's 1 day after that deposition. And with plastic, we're moving out to 3 to 4 days of the virus still being there. So if you think a lot of our public places, our supermarkets, for example, which might have plastic surfaces, if there is someone who is positive there, then unless that's being cleaned, then there is still risk of being exposed through that particular mechanism. And that leads us to the conclusion that stopping the spread is really simple. So we just need to not be near anyone who's infectious for a few hours or where they've been, and we need to not be where they've been for several days. So that's really easy. And that leads us to well, we can all just stay at home. Now, practically, that doesn't quite work. So we have to think about that a little bit differently. We need to be able to identify everyone who's infectious. And this is where the detection part comes in that I'm going to talk about a little bit later on. We need to isolate them and anyone that they have been near. And we need to clean everywhere they've been for several days. And so this is where the contact tracing becomes really important, because we need to be able to get ahead of that infection rate and isolate people before they can continue to be infectious in the community. So how do we detect COVID? Well, the obvious one is symptoms. We all by now will know the symptoms, right? So fever, any flu-like symptoms. Some of the quirkier ones are that you may have a change in smell or a change in taste. These are all great, but there's a couple of problems with using this as a way to detect whether someone has COVID. The first one is that you typically reach your peak contagious level before you start to feel sick or before the symptoms onset. And so there is this gap of exposure. I've been exposed to the virus. It then takes some time for me to be infectious. And after that, it takes some time for me to show the symptoms. That gap between when I have the symptoms and when I'm infectious is the really dangerous part that we need to try and identify people in. And we're not going to do that with symptoms. The other problem is, and there's been quite a few studies on this, that there are a lot of people who don't show symptoms, or at least have very delayed onset of symptoms. And that number looks to be about 20% for this work that was done in Queensland late last year. So that's approximately 1 in 5 people with COVID are asymptomatic. So that means that they don't know and are therefore outspreading. The good news, if you can call it good news, is that they transmit at a less rate or a lower rate than the people who do have symptoms. And that makes sense when you think about how the virus is spread. It's still not good, but it's slightly better. If we can't rely on the symptoms, we need a different test. And that means we need to have one that not detects the symptoms in our body's response to the virus, but actually to look for the virus itself. And that's where the famed nasal swab comes in, because that's one of the highest concentrations of the virus particles that's easy to collect to be able to run a diagnostic. On that swab is collected some of the virus particles, and you can see it on the right there. It's kind of a little ball. Inside the ball is the genetic material made up of the RNA. On the outside of the ball is a series of proteins that have different functions that enable the virus to survive and to replicate. We can either target the internal nucleic acids, the genetic test, or we can target the proteins to be able to detect the COVID. So genetic testing is the one that targets the RNA, and this is what's regarded as the gold standard in the way that most viruses and bacteria are detected. The virus inside the RNA inside the virus is exposed, converted with an enzyme into DNA, and then we do a process called thermocycling, which uses an enzyme to double the number of copies of DNA each time you change the temperature. So the temperature changes from about 68 to 95 degrees. Each time it goes up and down, you get twice the number of DNA copies. If you do this 30 times, then you end up with 2 to the 30 times more DNA than you had to start with. And that turns out to be about 1 billion times more. Now, if you've got 1 billion times more of something, it's much easier to detect than just detecting one virus or one copy of the RNA. It is the gold standard because it's exceptionally sensitive. You only need one copy. It's also the gold standard because it's exceptionally selective. False positives and false negatives are rare. Now, they do occur, but they are very rare because of the highly specific nature of the way that that PCR process works. But it has some downsides. The first one is it's slow. And when I say slow, I mean it takes a couple of hours for that PCR process to work, and it takes a little bit more time to do some of the preparation of your swab sample before that. It's not portable, so that means it has to be done at a central lab, or it has to be done at a specialized laboratory facility constructed near where the sample site is constructed. The turnaround time here is typically 24 hours. And there's a few reasons for that, but that delay of 24 hours is going to be important as I show you later on. The other downside is it's relatively expensive. Now, the best indication I could get of a price was about $100 to $200 per test. So that slow speed and that high cost mean that it's not really going to be a great option if we want to start doing more rapid, regular, high throughput screening to try and identify people who are infectious as soon as possible. Because if we can identify them quickly, we can get them out of the community and help to stop that exposure and reduce the transmission rates. The other alternative, as I was talking about earlier, is to target the proteins, and that's with an antigen test. And I've found it interesting the last few days that Sydney are now looking to use antigen tests to try and help manage the current outbreak that's there. And there's some really good reasons for that. So the antigen test is typically an ELISA. It's an enzyme-linked immunoabsorbent assay. It's a relatively simple concept that you take a surface and you put an antibody on the surface. You use that to then capture the virus in this case. And so we've now got the virus stuck on a surface. We then use another antibody that has an enzyme attached to stick to the virus. And then that enzyme is used to make a product. And because it's an enzyme, it just keeps working and working and working. So from one copy of virus or one virus particle, we'll get lots and lots of product to detect kind of like the PCR approach, although in a different mechanism. ELISAs are good, but they're not as good as the RT-PCR process, that genetic test. It's not quite as sensitive and it's not quite as selectively. It has higher false positives and higher false negatives. Now, higher false positives are not necessarily a huge problem, because that means that if you're identified as being positive and you're not, then you just have to isolate until you have a number of negative tests to say that, well, you're not infectious. The false negatives are the ones that are the problem, because that means that if you are negative, but you're actually not, you're still going about your daily activities and infecting other people. But the advantage is it's fast. And this is typically 15 to 30 minutes, and it can be done easily at site. The most widespread example of an ELISA is a home pregnancy test kit. And these are done at home millions of times around the world on a daily basis. So the platform and the capability here is really good. It's also cheap, and typically about $5 to $10 you can do an ELISA test for. But this is quick and this is cheap. But if we want to move to even higher throughput testing, this is still not quite acceptable. Why is that speed important? So this is some work that was published late last year, and I want you to focus on the figure on the right here and the two different colored graphs. So there is two different colored graphs there, and if I can find my spotlight, the red one here is the equivalent to the genetic testing, which has got super low sensitivity. The brown one here is essentially the antigen ELISA test, which is not so sensitive. On the bottom here, we've got daily testing, testing every 3 days, testing weekly, and testing every 14 days. And the numbers here, 0, 1, 2, is the delay from knowing the outcome of the result. So if I start at the pink one here, this is a daily testing with the highly sensitive PCR test. And if I know the outcome immediately, we can remove 100% of the infectious people right then. And if we do that every day, we can continue to remove people that come up as affected. If we delay the outcome by even a day, then we're not capturing as many people. And if it's 2 days, then we're now down to only taking out 75% of the infectious people. If we now look at that cheaper test here, which is not quite as sensitive, then if we do daily testing, which is about 10 times cheaper than that PCR testing, we're still almost removing 100% of the people. So to be able to have that instantaneous result, we can actually use a much cheaper test and do it more regularly than perhaps the more sensitive, more selective PCR test, and communicate less frequently the outcome. And this would allow us better management strategies. But as I said, that's still a little bit too expensive and a little bit too slow, because that ELISA test is going to take 15 to 20 minutes. Now, if we wanted to implement this before going shopping, for example, in a supermarket, you probably don't want to wait 15 to 20 minutes before you're allowed to go into the supermarket based on your test. And so that means we needed to think about how to test differently. We've been doing some work with airport screening for about a decade now, and that's where we have to detect explosives in under a minute, because that's the time period with which people are quite comfortable to be delayed without becoming apprehensive and annoying, I guess. Maybe that's not the right word, but that 1 minute time frame is one that we have all become accustomed to being acceptable with. So over the course of a decade, and with Grayscan, this technology has been commercialized for a 1 minute test of inorganic explosives. It was identified by the editor of the Aviation Security International magazine as being one of the 5 best inventions or technologies to improve airport screening technology in the world 2 years ago. And so this is the Grayscan ETV 100. It's a commercially available product being manufactured in Port Melbourne. You can see there on the video that it uses something like a piece of paper. This is what's called a swab. This is based on, this technology is being used to detect explosives on surfaces and maybe on your hands. And so you literally rub the surface and you stick it in, and in about 30 seconds there, you get an answer. Now that video was sped up just to make it a little bit more conducive to showing in a talk like this. What you're going to see now is that same piece of paper with the positive put on it so that you can actually see that it works again within that 30-second time frame. And I've used this video deliberately because of that piece of paper, because to me it reminds me of a car park ticket. And if you think about the dispensing machines that we have for those, you could conceivably think of one of these mounted in a supermarket entrance where you take your ticket, you potentially breathe or place a little bit of saliva on it, and then place it in the instrument. And 10 seconds later or 30 seconds later, you get the green light that you can go shopping. So we know all about that speed and that 1 minute time frame, which is much quicker than that 15-minute ELISA test. And so when the pandemic first arose, we started talking to the people at Grayscan about whether or not we could adapt that technology or any other airport technology, which is really quick to detect viruses in the pandemic. And we wrote an opinion piece on that, also published in the Aviation Security International magazine. We were actually very confident we could do that. And that's what we started working for probably about 8 months ago now. The difference that we have is that we detect the virus a little bit differently. We use an approach called electrophoresis, and I've got a little animation here to show you how that works. We apply a very high voltage, so 30,000 volts, over a solution in which causes ions and molecules and particles to move, and the speed at which they move depends on their charge and size. So you can see the little animation here. We're detecting sodium and then chloride and then bromide, because these molecules all have a different size or a different charge. When we apply this to virus detection and bacteria detection and any detection, we are able to separate, in this case, particles based on their different properties. And that's really different to the existing tests that we there, because we see the virus. We don't see the RNA inside the virus. We don't see the proteins that are on the surface. We see the whole virus. And if you think about the surface issue and having viruses on the surface, the question then is, well, if I clean the surface, how do I know it's clean? Because the way that you clean it will actually degrade the virus into its RNA and its proteins. So you'll still get a positive response there. However, with our approach, being able to detect the intact virus, we would be able to distinguish between viral remnants from a cleaning process, for example, and something that is actually an infectious surface. So about halfway through last year, a team of people from the University of Tasmania, Grayscan, who are the company that make the ETD100, and Deakin University came together to see if we could start and adapt that technology to be able to detect viruses. There's a huge number of people that have been involved in this. There's only a few of them shown on the screen here, and every single name and every person has been absolutely critical to being able to achieve what we have so far. And you know, I can't express my thanks enough for the way that we came together as a community to try and solve the problem of really fast, and I mean really, really fast virus detection. So where are we now? So we detect the virus, not just the protein, the RNA, and we've actually shown this, and we've shown that for a few viruses now. Influenza, we can detect in 2 minutes. We have some issues remaining that we have not quite sorted out yet to be able to detect COVID. We're actually very positive that we can still do that. We're not quite there yet, so we don't have the scientific evidence, because I'm an academic, to say absolutely that we do have COVID capability. We have got a lot of evidence that suggests that we do, but we're not quite there yet for my satisfaction. We've shown that we can detect viruses on surfaces using that swabbing extraction process in saliva and potentially in breath. We still have a lot to do, and with the increased rates of vaccination that we all have to do to protect ourselves and our community, the necessity for detection perhaps is easing off. But I think it's still important to have this capability in case the virus evolves again. And of course, you know, the last virus infection, I think, was MERS. That was not too long ago, and SARS-CoV-1 was before that. And so perhaps maybe not to the same global extent as the COVID-2, but I think there still will be areas where this really rapid virus detection capability is going to be important to help us as a community manage the spread of that infection while still being able to operate as close as we can to normal. So I'm going to finish up now by thanking the team, some of who you can see there, funding from Grayscan and the CSIRO, and the WHO Collaborating Centre for Research and for Reference and Research on Influenza, and the Doherty Institute, who provided us with some virus samples to be able to develop that test. Thank you very much for your time today. And at the end, if I can, I will answer any questions that you might have.
Thank you very much, Michael. We thought we'd garner a bit of attendee participation, so we thought we'd run a quick poll for everybody's interest that relates to vaccination. So I'll just ask the team if they can put that poll up. And we'll just leave it there for a little bit. So please feel free to answer to that poll, or if you'd prefer not to say, there's a box for that as well too. So we'll bring back also to, while you're thinking about that, our panelists and main speakers. That's Nicola, Mark and Katie, along with Michael. And I thought I'd just ask each of the panelists initially to give any reflections on Michael's presentation, but also ask them to crystal ball a little bit and try and forecast where they think Tasmania, Australia and the world will be a year from now, July 2022, with respect to the pandemic. So I might ask Nicola, would you be able to maybe go first on that one?
Happy to. Thanks, James. Thanks, Michael. That was fascinating and exciting. I think the grey scan method for virus detection, if we can get there for COVID, would be a massive step forward. As far as thinking forward and what that might mean, to my mind, we have a variety of things coming together. We need fast detection of the virus so we can isolate people. We need vaccination, of course, to be very high. And we need that test to be fast. I think what we need to keep in mind as we move forward is that we hope that we will move into a world where people will think of getting vaccinated against COVID in a similar way to they do other vaccine preventable diseases. So measles is a good example, where somewhere like Australia, we have such a high coverage for measles. Hopefully in a year's time, we might be approaching that sort of vaccination coverage for COVID in Australia. But of course, there's always going to be people that can't be vaccinated. So vulnerable people in the population who, for whatever reason, are unable to be vaccinated, and we still need to protect those people. So these sorts of methods, no matter how far ahead we get with vaccination and coverage, we're still going to need methods to be able to detect this virus and isolate people, and for people to self-isolate if they are infected. So I was excited to hear what Michael was presenting. It's always one of our frustrations when we have to wait for test results for people that are waiting for them for public health action, but also for the people who are waiting. So there are so many benefits to that. But I do think that, yes, in a year's time, my hope is that we have a community that have changed how they think about this vaccine to being a very standard way, as we do with many vaccine preventable diseases, and that our vaccine coverage is really high, and that we can combine all of these things to protect the vulnerable. And I think we will be, as much as people might not like to think we are, we will still have situations where we have outbreaks, and we will still be contact tracing and following up so we can stop broader outbreaks, because even if we have a large population who are vaccinated, they themselves might be protected from severe illness, which is great and great for our systems. Our hospital systems won't be overrun, but we do need to keep the vulnerable in our population under our thoughts at all times.
Thank you, Nicola. Mark, would you like to go next? Mark may have gone off to. Oh no, I think he's coming back on.
Sorry, I think I've got there. Am I audible?
You are.
Thank you. And look, thank you, Michael. That was fascinating, and I can definitely see how, with appropriate development and placement in the right context, the technology has great prospects of being very useful as we work our way out of COVID. There's certainly been a lot of different test developments as we've gone through the pandemic so far. As a country with generally pretty good access to PCR-based tests and mostly not much disease around, there's been a fairly solid preference for the gold standard tests, but there's definitely been moves to adopt more rapid technologies where the circumstances make them a better call. And I think your rather complex graph that showed that interaction between test sensitivity, frequency of testing, turnaround time, and getting infectious people out of the community got to the heart of that. Certainly in Sydney in recent days, they've turned to use the rapid antigen tests quite extensively to go into settings where they know there's a lot of disease, where the operating characteristics of the test can be less than perfect, but it can still be the best call to give a basis for public health action in those circumstances. And the test technology that you're describing has a similar sort of flavour for how it might be used. Where will we be in 12 months' time? I think we'll have COVID amongst us then, and we'll be living with it. I think we're going through a really interesting time right now, because I think we perhaps, and maybe this is my feeling and I'm projecting it, I think perhaps late last year through to early this year, we thought we'd just get lots of people vaccinated and we'd move without too much drama through to a situation of living with very little COVID amongst us, but not having our lives disrupted. I think that was probably somewhat wishful thinking. And I think that what we're seeing now with the experience of a number of countries overseas that have had high levels of COVID throughout, are achieving reasonable levels of vaccination, but still having lots of COVID, is telling us exactly what Nicola said, is that we're really going to have to get the vaccination coverage very high to minimise the effects of COVID on the community, and also to minimise the number of additional measures that we have to have in place to mitigate the risk. So, and I think that's looking at something we know well north of 80% of the population having to be vaccinated, and that's going to need to be coverage widely across the population. It's going to have to pick off the people who transmit the disease more frequently, which is young to middle-aged adults. It's going to have to be very high coverage in those people who are most vulnerable to severe consequences of COVID. So it has to be a very broad approach. And I think the Tasmanian approach to vaccination has had a lot of those features. So I think that's a good thing. What we're probably working our way through at the moment with the help of mathematical modelers and others is to look at what level of social restrictions we're going to need to have in place as we move towards those very high levels of vaccination coverage. What will we have to in place? What might we have to pull out and impose, perhaps a bit regretfully, but maybe necessarily, until we're at a very high level of coverage. And the other thing that we'll need to do is to have robust measures of contact tracing, testing, tracing, isolation and quarantine, as it's known. We'll probably have to have, as Nicola said, some of that still continuing. Historically, that's been a very approach using fairly basic strategies that served us actually quite well in Tasmania early last year. But increasingly, we're using technological supports to improve our contact tracing. And that's where things such as Check-in Tas are involved. On the other hand, we have to make sure that if we have a lot of technological measures, we've got the human back end to that to be able to manage that information and to put good public health measures in place. So I guess in short, high vaccination coverage achieved over the next 4 to 6 months, the right mix of as needed social measures and restrictions, and an ongoing robust public health response arm. And above all else, we of course have to keep the community on board to communicate clearly what we're doing, what we're asking them to do, and being very honest about what we know about how things are and what we don't know.
So thank you, Mark. Katie, would you like to offer some comments?
Yes, and thank you very much for inviting me to this, and thank you, Michael, for a great talk. That was really interesting and inspiring. I guess this is sort of technology, really. It is changing everything in the COVID field, this world, and the COVID world, and has been a very exciting year with all the different technologies that have come forward, all the different detection tests and everything else. And I must say, speed of testing is very important in our hospital, just with running the hospital, to get a rapid result, to be able to identify staff and keep them in the hospital. Otherwise, they'd all be going home and waiting a few days for results. And to reassure doctors, although we know you can't rule out COVID from a single test, but there's many doctors that get very frightened if they're taking someone to theatre and they've got a bit of a cough or a cold. So actually being able to detect the virus is really important. But I thought I'd expand just a little bit more on vaccination. As a member of ATAGI, and I'm not speaking here on behalf of ATAGI, but we've obviously been in the media a lot, and we've been really trying to get the vaccine program right. And I think it's incredibly complex. It's been moving so fast. But I just wanted sort of to put people kind of in the picture a little bit more. You know, there are now 289 vaccines that have been developed in the last year in the world. I mean, if that isn't a technology explosion, I don't know what is. That's never happened before for any infection. And so we've also got multiple different platforms. We've got novel platforms. They've never been actually licensed for human vaccines before. So this has just been a phenomenal thing that has happened. And interestingly and excitingly, there's oral vaccines coming, there's inhaled vaccines coming. So we may actually just be able to take a tablet or spray something up our nose, and that may actually protect us against COVID. If we're thinking about in a year's time, well, Tasmania is doing really well. It's leading in Australia in terms of vaccination rates. We've got the highest rates in the country at the moment and have had all the way along. And I think that means the population's very engaged. But as Mark said, very good public communication to maintain confidence about everything we do is absolutely essential here. Looking globally, 4 billion doses almost have been given throughout the world, and we've got a world population of almost 8 billion. So that is a lot of vaccine. However, it's been focused on the richer countries, and still many of the poorer countries have got a minimal number of people vaccinated, and many have not got their vulnerable people or their healthcare workers vaccinated. So if we don't get that right by next year, this whole world will remain vulnerable. We still won't be able to travel safely. And that is going to be the crux, actually, doing that. And it is good that Australia has bought into CEPI, the Coalition for Epidemic Preparedness Innovations. They've invested in that. And that's the facility that is putting money in to guarantee vaccine for this country. And that was when we didn't know which ones would be efficacious, but also money to provide vaccines for poorer nations of the world. And there is an effort going into our region as well with providing vaccine. We clearly have a huge amount of AstraZeneca vaccine, which is a very, very good vaccine. It's just unfortunately had these safety signals. And so that is going out to our regions of the world, and that is going to be really important. So I guess in a year's time, we could easily have a decent proportion of Tasmanians vaccinated. We're always going to have some hesitancy. I think that is a huge risk for the country. Hesitancy rates are going down. But we do need sort of in the region of 80% of people probably vaccinated. We have got to develop the children program, well, first of all, the adolescent one, now that the Pfizer vaccine is licensed for the 12 to 15-year-olds. And chances are we'll be de-escalating down from there, because the children are actually showing quite good susceptibility to these variant strains. We don't know what variants are coming. But I would imagine and hope that in a year's time, we'll have most of the Australian population fully vaccinated with their first 2 doses, and we'll have to be working out what the ongoing program is going to look like, how frequently a booster is required. We don't know how long immunity lasts from vaccination at the moment. We don't know which vaccine is going to perform best. We don't even know, when we boost, which one can boost against which vaccine. So there's a lot of unknowns here. There's still an awful lot more work to do. I guess I think I'll just leave it there. There's a lot I could say about where things are going at the moment. But as we've all seen, we've been very caught by this Delta variant, and it's shown that this virus mutates, can become much more easily spread, and also much more aggressive infection. And many of the people in ICU at the moment in New South Wales are in their 20s. So very concerning. Thanks.
Thank you very much, Katie. So again, just to encourage everybody attending today to ask questions. They can be questions to Michael and on his presentation, but there can also be questions to our panelists. We're very lucky to have a very rich layer of expertise with our panelists today too, so I'm sure there might be other questions. Just please use the question and answer tab. Should be at the bottom of your screen to ask those questions. Some are coming through. I wonder also if we've got the results of our poll on vaccination, maybe, that we could pop up for people to have a look at. So again, we may have a bit of selection bias, obviously, in people who have come along to the presentation today, but I think it also does reflect that Tasmania is doing quite well. The Tasmanian population is attending to their vaccination status, I think, quite well. Obviously, we're still looking for more of the community to make sure that they become vaccinated. So some of the questions that have come through, Michael, this one's probably to you. Can you potentially forecast what the cost of your test would be on an individual basis, and maybe some comment about its portability as well?
So the good question. The system is, it's not handheld, but it's kind of like a small suitcase, so about this big. It's certainly portable and is operational within about 20 minutes of being set up. In terms of cost, that's not really an academic answer, that's a commercial answer. We are hoping that it would be somewhere less than $1 a test, but there's a few things in terms of the manufacturing cycle that need to go through to be able to determine that cost accurately, and we're not quite at that point yet. And
are there ways that you can design the test or implement the test so that it will work for different variants, and maybe tell us what variants may be detected?
So when we were doing our testing, I think we had the original strain and the beta strain, and we were able to detect those, or our system showed that it could detect those. We didn't at that point have any of the Delta strains. So we can detect, I think, all of the strains. We, at this point, don't have enough evidence to say whether we can distinguish each strain.
Okay, and maybe a broader question for the panel. I guess there's a concern that there might be antigenic drift or mutations of the virus within the vaccinated population, and if that's true, do we need to continue the other measures that we have, such as hotel quarantine? Any volunteers? Please unmute yourself. Katie? Maybe?
I thought Mark might like to start about the quarantine and likely measures. However, look, this virus will continue to mutate. With the vaccination, it still only gives about 50% protection against transmission. So that is a good thing, but it's still not 100% protection. Nor does the virus 100% protect everybody against getting the disease. You may get less severe disease, you're much less likely to be hospitalized and die, but it's not 100%. So there's still the risk. And then people that have poor immune systems, other susceptibilities maybe get it. And of course, there's also going to be the people that don't get vaccinated, either because they choose not to, or for one reason or another, they can't. So I think this is we're living with this for the future, and we're going to have to adapt to this virus, and we're going to have to have on and off public health measures while we boost up immunity until eventually we have an endemic virus that we can handle. But occasionally we may have some very mutant and aggressive strain come through, and we may need very special measures to control that. So there's always going to need to be a combination. But vaccination is going to really change the face of things if we can get really broad vaccination coverage.
I was going to jump in, I just couldn't get off my mute button, but thanks, Katie. Yeah, I think one of the things that that's important to communicate is that vaccines aren't 100% effective, but they do a good job. I don't think we've done a great job of communicating influenza vaccine benefits, efficacy, and shortcomings over the years. But I think we're doing a better job with communicating COVID. As Katie said, that there is some reduction, I think Katie said, there's some reduction in the efficacy against transmission prevention and serious outcomes for the Delta strain, but it still achieves substantial protection for most people, and will in combination with other measures, give us a pretty good chance of controlling COVID to a level that it's a manageable disease in the community if we can get the vaccination coverage high enough. I think there's going to be a really interesting phenomenon occurring over the next year or so, where we get a mix of immunity due to vaccination, immunity due to infection of vaccinated people, and booster immunity, which is a really complex equation. And I don't know that people have completely thought it through, but it has the feeling to me of being on the verge of seeing how a new virus introduced widely to the human population in a way that we haven't seen it really in any of our lifetimes. And it's a different virus altogether from HIV. It doesn't have which doesn't have the propensity for population-wide spread. But the kind of, don't know that it will see human evolution on that timescale, but the effects of sort of human and viral co-evolution over the next 12 to 18 months is going to be fascinating. Are we going to see the virus increase in transmissibility? Are we going to see it reduce in virulence? And how is that mix of vaccine, original vaccine immunity, boosted vaccine immunity, and various forms of wild disease transmission going to affect that evolution and the implications for both humans and the virus? And that's going to be really interesting over the next year or so. And I think it's probably completely unrelated to the question that we were asked, but
it was very interesting nonetheless. But I guess there's a related question, I guess, that with vaccination often serving just to reduce the symptoms of COVID, could there actually be lots more asymptomatic or less symptomatic cases let loose throughout the community as a consequence?
Potentially so, but as one of us has said, that fortunately, mostly those asymptomatic people are less infectious.
And I think most of the last,
vaccines,
sorry, Katie. I think most of the last questions, sorry, Katie.
Yeah, no, go for it.
I just want to add that what both you and Mark were saying, Katie, probably support Michael's case for a faster way of detecting cases. And I think that moving forward with these new strains coming through, the need to detect quickly and have something on hand, so when there are occasions where there are large numbers of people together where there's potential for a lot of spread, something like this fast detection kit could work really well.
Katie, did you want to add something?
Oh, look, all I was going to say was that the vaccines, we know they give some protection against asymptomatic infection as well. But it's, again, nowhere near 100%. It's more like 50% protection against that too. But yeah, I mean, the vaccination will reduce spread, but it will not 100% curb it. And what we need to do is protect those people that are more likely to die, to stop overwhelming our hospitals. I mean, this was one of the hugest concerns, really. We would not have been able to cope with an exponential surge in COVID in this country, and we would have had the similar situation to what other countries experienced. So we've now understood how to manage that, and we are trying to vaccinate our more vulnerable, but it doesn't mean that younger people won't get this and die as well. So it's so important just to get that pan-vaccination coverage.
And then maybe, Michael, back to you. There's some really good technical questions, which is what sort of, and I know you may well have some constraints on how you can answer them, but what sort of specificity and sensitivity would you be aiming at for the kind of test that you described?
So we'd be aiming to be at least equivalent to the current antigen testing.
Okay.
So that's our benchmark, but we want to be 10 times quicker and 10 times cheaper.
And would the goal also be to be, I guess, scanning for multiple variants at the same time and other viruses? Can you multiplex this in some way?
Yeah, so that was one of the reasons why we have influenza in our mix, so that we can distinguish between influenza and COVID. And then hopefully we can still then start and develop the different strains to get that additional specificity of which particular strain of the virus you're infected with. So it's a multiplex test. We're not quite sure how far we can multiplex at this point, but we're certainly capable of doing maybe 2 or 3 quite easily.
And I guess related to this, and again, feel free not to answer the question, but do you do a lot of your tests or develop tests based on dead or deactivated virus, or is there a potential to look at live virus?
Yeah, so everything at this stage has been done with the activated virus, and we know that there is a risk then that it may not transfer as easily to live virus, but that was very much a deliberate choice because we weren't actually able to handle live COVID in the state. And with our low infection numbers, we weren't likely to get some positive samples anyway.
Okay, good. And also back to vaccination, there's a lot of questions that are very common out there, I suppose, in the public sphere at the moment. And one of them relates to what we've seen, I think, glaringly quite recently, which is around anti-vaccine sentiment and hesitancy. What are the thoughts on what we can be doing to, I guess, counteract that to some degree, or at least to be looking how we encourage people to think about getting a vaccine if they're eligible? That's a pretty broad question, but anyone would like to have a punt at it?
I'll
Katie?
have a go.
Oh, maybe Katie first, then you.
Katie, yeah.
I was waiting to see if the others wanted to have a go. Look, yes, hesitancy, actually, I think we've recognised for a long time is one of the greatest risks, really, if we really want to get broad vaccination coverage. Hesitant people can be persuaded. There's certain people that will never have a vaccine, and we know that, and that is what it is. But that hesitant population, a lot of it is about communication, and really communication from trusted local sources, because a lot of the hesitant communities are people, perhaps the culturally and linguistically diverse community in particular, quite hesitant. But if you engage with the community, get materials in their languages, get their trusted and respected community leaders to speak to them, then that really works as well. The Aboriginal and Torres Strait Islander community was at some point a little hesitant as well. At Otago, we've been engaging with their COVID advisory group for the Aboriginal Torres Strait Islander community. In fact, we had a meeting with them yesterday to discuss the paediatric and adolescent program, and doing that engagement, and then they disseminate out to all of their groups is the way to really try and help with some of that hesitancy. Really good clear messaging in the press as well, in advertising, and just trying to dispel some of those myths. And I think, you know, the press also have a huge responsibility here to report responsibly and not to just be sensationalist and create stories of drama about this vaccine doesn't work and that does. AstraZeneca got such a bad name in this country, and actually when you look at the real world effectiveness data emerging, it's behaving almost equivalent to the Pfizer vaccine in terms of protection against hospitalization, death, and getting disease. And there are huge studies that have been done in the UK and in Europe. And so I think, to my mind, it's all about good communication. And I think the more public communication that's done in a responsible and very effective way, the better. Over. Thanks.
Thanks, Katie. Nicola, do you have...
Katie's covered exactly what I was going to say. And I think there's been vaccine hesitancy has been around forever as well. And we know quite a bit about it. So following the principles of what's been found out about other diseases with vaccine hesitancy, and it's all about the communication and how we communicate.
So I guess it's a somewhat related question, and again, not to put Katie on the spot, but you know, Otago is something, you know, now all the country knows about. It's quite happy group of colleagues working together up until it, you know, reached you know, quite, I guess, extreme public notice. I mean, how do you feel about the political pressure that's out there on Otago to modify advice around vaccines?
It's interesting. I joined Otago a month before COVID appeared on the scene, not realizing it was going to dominate my life to quite the extent it has. Look, you know, we advise the government. The government then decide whether they want to take that advice. The way it's been reported has not always been entirely correct, and that's just what it is. I think there's politics here, but there's science here. We advise based on science. We will stick to our advice. We will not be pressured to change our advice if the government wants something different. They sometimes come and say, look, this is sort of the way we're thinking, and would you agree with that? And if we don't agree with it, we say, no, we don't agree with it, and we will give our advice as it is. And that's been very well accepted. And in fact, we're working really well with the government, and we meet with the task force every week, and we have meetings with Paul Kelly every week and with Brendan Murphy. And, there's been a really good communication. And with the advice around AstraZeneca, that was very, very difficult to make. And we knew that it was going to cause a lot of problems. But, at that point, the risk benefit just didn't really sway in favor when we knew that Pfizer would have been safer at that time. That has changed. And in fact, if you look at the advice that we gave at the time, we gave a whole load of different epidemiological scenarios and pointed out that at some point COVID could just sweep through and people be inundated and it'll be too late if they haven't vaccinated. And that's playing out to a certain extent now in Sydney. So whatever the press are reporting, we're not being pressured to change our advice. We meet every week now and we discuss TTS cases, and we're now discussing myocarditis cases with Pfizer vaccine, and other safety signals as well, and a number of other things get discussed. And we will continue to do that and continue to try and follow the science. We also work closely with the mathematical modelers, including the ones that are doing the modelling at the moment for the government. And there's, we have ethicists, we have all sorts of people on the panels that are advising, and we just continue to do the best job we can, despite the fact that we're a little bit too much in the press at the moment, I would say. Thanks.
Thank you, Katie. I guess there are related questions in the Q&A, which is really, I think, about what you think about it. What is the advice to be giving to younger members of the population, particularly with respect to AstraZeneca, through to, I guess a pertinent question really, that given Tasmania at the moment, where, there doesn't seem to be COVID-19 in the population, so the risk remains, but what do we think about using AstraZeneca in Tasmania, given the position we're in at the moment? So younger populations and Tasmania, what do we think about that?
Well, I guess the advice that we gave at ATAGI remains. We would recommend, if you're under 60, that you actually do get the Pfizer from a risk-benefit approach because of the epidemiology, but recognizing that we only have to have one case of Delta slip into the community we may not know for 2 weeks, and we could suddenly have Hobart or Launceston or anywhere else locked down with cases just exploding everywhere. We just never know. We're hoping that doesn't happen. And if you wait until that happens, it's going to take up to 3 weeks to get decent protection from that first dose. And in fact, we know that against the Delta strain, 1 dose of either vaccine is not particularly fantastic. And actually, you'd need the 2 doses of the vaccines. And, that's one of the reasons we've had to say in New South Wales, if people want to come forward early, they're probably going to benefit more by that extra protection against the Delta strain, even though the overall protection won't be as high as when you get the vaccination later. So in terms of what to advise people here, I think people have to think about their lifestyle, about their risk benefits. Are they immunosuppressed? Have they got other comorbidities? Have they got family members that they might bring COVID to if they visit them regularly? Other vulnerable people they're in contact with? What's their job? Are they teaching? Do they need to keep going to school? Are they working in essential services? There's lots of many factors there. And Pfizer is available to a lot of people, and we know that the amount coming is increasing. And by the end of the year, and in fact, in the next couple of months, we're going to have pretty high supplies of it. So I think people just have to weigh up that risk benefit with their GP and think about it. Every case is different. And unfortunately, we did lose a 44-year-old Tasmanian a couple of weeks ago from having the AstraZeneca vaccine. But it's a 1 in a million chance of actually dying of TTS. Quite a high rate of getting it, but not many of those people actually die. And we really know now in Australia how to recognise it and manage it very, very effectively. In fact, we've got the best case ascertainment in the world now, and we're managing our mortality rate from TTS is really low.
Thank you, Katie. Any other comments on that one? If not, I'll go to a different kind of question, is that we are focused today on detection and then also immunisation. But what about non-immunisation strategies to handle COVID, particularly in people who become infected? So what about other drug treatments? Certainly we heard about controversial drug treatments very early on in the pandemic that didn't quite turn out to be terribly useful. But what do we think about development of these drugs for managing symptoms and I guess potentially inhibiting some of the the most awful outcomes of infection?
I guess as an infectious diseases physician, that will come to me as well. Look, there's been so many drugs out there that have been tested and people have said, oh, they're going to be fantastic. Hydroxychloroquine, Trump was on the bandwagon saying everyone should take this, it's fantastic. And in fact, the trials have shown that that's not true. And in fact, causes more adverse events than it causes good. We have got remdesivir, which is an antiviral, which we can give people. Adjunctive steroids for people who are going to need oxygen and ventilation seem to benefit them as well. There are monoclonal antibody treatments being developed, which have some efficacy as well. But the trouble is that often people are presenting late, and it's almost too late for an antiviral once you come into hospital and you're starting to deteriorate, because often a lot of the damage is done. And what it is not actually the virus now, it's your immune system that's kicking in and causing all the grief. So a lot of the cytokine storm and the T-cell lymphopenia, but also the cells that all get infiltrated into the lungs, all that is already in process. So we've got just a very small handful of things that work, and lots and lots and lots of clinical trials happening all over the world, keeping on trying to find an agent. And there's been so many different ones tested, antivirals, but also antiparasitic drugs and antibacterial drugs and everything. And I guess eventually we will find a panel of things that work, but at the same time, as I say, because people present late, it's the same with trying to treat flu. We often get the patients with flu a little bit too late to give them treatment as well. And most of the treatments available, the antivirals, you need to get in early to actually get a good clinical outcome. So I guess that's what I'd say at the moment. We do have a few things we can use, though, as I said, that are available, such as the steroids and remdesivir.
Excellent, thank you very much. Michael, another question back to you. Let's envisage your technology is successful and widely deployed. Do you have a view, or maybe even the panelists, about how it would work in practice in the community? So, what if somebody's at the local supermarket and they're tested and it becomes positive? They get a quick positive result. What happens then? So, what do you think might be the protocol that happens after somebody gets one of these?
So I think there's quite a few different number of use cases, James. In that one in particular, I would expect that person to immediately be prioritised for a PCR test and quarantine, and then contact tracing beginning as a result of that PCR test. That's what I would assume would happen. Whether that is what would happen, I don't know, and that is one of the I guess the challenges with putting it somewhere where people or the public might walk up and access. It's then your responsibility to deal with the positive result. Whereas if it was managed, say at an airport or something with a person, then you may have a different response. So I'm not exactly sure how it would be rolled out and where it would be used, but it's unlikely supermarkets would be our first priority target.
Does raise some conundrums there, doesn't it, potentially out there?
Yeah, they're great questions to have, and I guess as an analytical chemist, I would go, well, if we have the technology, we can start and answer those questions, because they're really good ones to be having and talking about how we would use it. There may be better high-value places where it would start initially, such as in the hospitals, as I think either Katie or Nicola said, just to keep on top of staff and whether they are healthy. Because if we can get them back into our workforces quicker, then we can deal with everything quicker. So I would expect our workplaces would probably be our first priorities. I expect I think our original target market was aeroplanes and the international people coming in. And you test before someone gets on the plane. You test every person before they get on the plane, and you test every person when they get off the plane. And if there's no change in infectiousness during that transit, then there's a good chance that everybody's okay. Now, it's not 100% reliable, but it's all about confidence and having more information as quickly as we can.
I mean, I'd just like to add that I think it is really important that any testing is done in a carefully thought through clinical and public health consequence about what the meaning of that positive and negative test really is. And certainly there's been use of rapid antigen tests in various remote workplaces along the sort of lines that you're suggesting, and that certainly has merit. But even that can miss cases, as we learned a few weeks ago in the Northern Territory. The other consideration, of course, with flights and so on is we're always going to be really careful we don't give people false reassurance that they couldn't possibly be positive. And a negative test with imperfect precision that's taken by someone to mean they definitely don't have it. It may be no fault of the test. It may be just they'll test too early for the infection to be manifest. Could give rise to problems if they then think that they don't pose a risk and go out and pose a risk. So I think that context, the use in context needs a little bit of thinking through.
Yeah, very good points, Mark. I honestly, I wouldn't be doing that, and I don't think our partners would be doing that. And I think it's people like you who would be helping to advise exactly how this might be rolled out anyway. Yeah,
I mean, you get it, and I think many of the people in the audience will get it, but a test is just that, it's a test. You have false positives, false negatives. And I think that's something that's part of the scientific literacy that might have developed as we've gone through this pandemic, rather than, I remember talking about false positives and false negatives in press conferences a year ago. And they were kind of
confused.
Emergence of blamey culture back then, you know, there's something wrong that this test is negative or positive. Why isn't it absolutely 100% black and white? But I think that there's probably been an increasing understanding of the limits of tests as time's gone by. That's kind of a public understanding of science thing, and it's kind of one of the remarkable things of the pandemic. You know, the number of people who would have thought that people would have understood what an effective reproductive number was, been on the front page of the newspaper 12 months ago. Some of us love that stuff, but we never thought it would be public.
Like in lectures to some of our medical students before the pandemic, I used to say the 20th century, you know, was when we moved away from being too worried about pandemics and infections at a population level, and boy, was that proved wrong. We're towards the end of our time today, so again, my personal thanks to all of the panelists. I think one of the comments that we got was to pass on to Mark Veitch in particular, that he's doing a phenomenal job during this time. So thank you, Mark. But also we know Nicola and Katie too are extremely active in the states and the national response to the pandemic. And we also have Michael, who's developing frontier technology for us, so to hopefully make our lives much more easy and help to control the spread of the virus into the future. I'd now like to invite Dr. Rob Walters from the Cobbold Lecture Committee to provide a vote of thanks. Thank you, Rob.
Thank you very much, James. Look, I was delighted in 2011 to be asked to assist in establishing this annual event in honour of Arthur Cobbold, a man to whom a number of the Tasmania University medical graduates owe an enormous debt, but also hold an enormous affection. Arthur was a wonderful man, a wonderful raconteur, but more than that, he brought a touch of the common man to the deanship, and was very formative in a lot of our lives. His wife Elizabeth, unfortunately, is unwell at the moment, but I'm sure she will be able to watch this presentation as it's been recorded for YouTube, as will Astrid and David, the Cobbold's children. The request when establishing this lecture was that it be delivered by a UTAS graduate about a contemporary health-related subject. Well, I can't think of a more relevant subject than what we've heard about today. A number of the speakers have actually said during their presentation that we live in interesting times. I understand may you live in interesting times is in fact a curse, and I'm sure that people in Victoria and New South Wales will identify with that curse. So to our guest speaker, Michael Breadmore, thank you very much, Michael, for a fascinating presentation and for simplifying the process of rapid detection and how it works, and indeed hearing about the work that's being done here right in Tassie. As a GP myself, frantically vaccinating as well as doing our normal duties, to have a rapid detection would be just would transform our work day. May I also thank Nicola, Mark and Katie for their comments from the coalface and endorse that comment of what a great job they are doing out there right here in Tassie. And I'm sure that it's no small part why we're living as relatively easily as we are, the work that's being done by our colleagues. To the committee, thank you for your hard work in getting this webinar to air. All in all, I've got to say this was a very interesting session, and Arthur would have loved it.
Wonderful, thank you, Rob. And I'd also like to extend a thanks on behalf of UTAS to the Cobbold committee that involves Rob as well as Owen Breen, Lindsay McLeod and Amanda Veitch, and also Linda Brock and her team for supporting the webinar today. This series continues with upcoming online public lectures and forums that you'll see listed there on your screen. I'd like to strongly encourage you all to continue the discussion by registering for these talks. The university is looking forward to continuing the ideas, debate and discussion that we need for and from Tasmania. So thank you to all the attendees for taking part today, your excellent questions, and good afternoon.